I have to talk on relatively low testosterone levels with erectile dysfunction. Dr. Jivani is in front of me. So, first of all, what is erectile dysfunction? Erectile dysfunction is defined as an inability to attain or maintain penile erection sufficient for the satisfactory sexual performance. And it affects about 52% of men aged 40 to 70 years. Its prevalence increases with age. The global prevalence of low testosterone is also between 10 to 40%, and it is higher in the men with obesity, diabetes and metabolic syndrome. However, low testosterone affects 40% of the men aged 45 plus years, and only 2 to 21% of the individuals have both the conditions simultaneously. And the clinical significance of this is that it precedes the cardiovascular disease by 2 to 5 years, and both conditions significantly impact the quality of life and the relationships. So, how erection occurs? It is a coordination between the brain, hormones, nerves, muscles and blood vessels, and primarily the mechanism involved imbalance between the factors that promote blood flow into the penis and those that cause the blood flow exit. And the etiology of erectile dysfunction is closely related to cardiovascular disease, diabetes mellitus, hyperlipidemia and hypertension. All the things, those cause endothelial dysfunction, and endothelial dysfunction is basically the cause causing erectile dysfunction. It is mainly an organic disease, but some may have psychological issues, particularly in young men. So overall, we can say that the erectile dysfunction is not only governed by testosterone, and there is no exact testosterone levels, whether they are normal or low testosterone level, which are actually required for normal erection. There are multiple causative factors for having erectile dysfunction. There is sexual stimuli, visual, olfactory, imaginative or tactile. They secrete dopamine, oxytocin, nitric oxides, autonomic neurotransmission. Then there is the effect on pelvic plexus, and then there is somatosensory neurotransmission, and ultimately they lead to penile erection. And if we see the physiological process, it starts with sexual stimuli, then there is a nitric oxide release leading to guanyl cyclase activation, then cyclic GMP generation, then calcium uptake reduction, then cavernous sinus dilatation and venous outflow compression. And this, and in the end, the phosphodiesterase 5, they degrade the cyclic GMP and it causes determinescence. So this is the pathophysiology behind erectile dysfunction. Now, what is relatively low testosterone, or we can call it a symptomatic borderline low testosterone. So testosterone can be classified as total testosterone, free testosterone, and bioavailable testosterone. Bioavailable testosterone is free plus bound to albumin, which can be readily available. Normal range is said to be between 300 to 1000 nanogram per deciliter. There is circadian variation higher in the morning. Single low measurement should never be used as a marker, and it should always be repeated, and not overt hypogonadism, but levels lower than end of the normal or mildly reduced may cause symptoms, and it may be below the individual's usual baseline or low for age or for the health status. All these things can be classified as symptomatic borderline or low testosterone, and it is clinically important because they can cause low libido, erectile dysfunction and fatigue, and they can occur with the borderline low testosterone level. Now coming how they are interrelated, low testosterone and erectile dysfunction. There is significant overlap. There is a population which are experiencing erectile dysfunction as well as low testosterone. There is not always a direct link because testosterone is not crucial for normal erection, not always very much crucial for normal erection. Direct cause and effect relationship is not always clear cut. However, decreasing testosterone is observed in men with erectile dysfunction, but not all men with low testosterone level have erectile dysfunction. And it is being seen that testosterone therapy helps in patients having severe hypogonadism. This is the chart where you can say that from hypothalamus there is a release of GnRH, which causes a release of FSH and LH. FSH is responsible for spermatogenesis, and LH, they act on Leydig cells and cause release of testosterone. Now testosterone has many effects. It acts on the brain, leading to dopamine, release of dopamine and dopamine receptors. It acts increasing nitric oxides, and this nitric oxide increases cyclic GMP signaling and cause enhanced penile erection, and dopamine and dopamine receptor, they cause increased libido and sexual activity. So they are mechanistic category linking low testosterone to erectile dysfunction. They are neural mechanism, vascular endothelial mechanism, smooth muscle corpora cavernosa changes, nitric oxide synthesis and signaling, psychosexual and libido effects, and indirect metabolic and inflammatory pathways. Coming to them one by one, neural mechanism, testosterone modulates central libido, acts on the peripheral nerves, so low testosterone causes reduced central sexual desire and decreased neural drive for erection. Vascular endothelial mechanism, testosterone supports endothelial function, and low testosterone is linked to endothelial dysfunction, so impaired nitric oxide release lead to poor penile arterial flow. Nitric oxide synthesis pathway or nitric oxide signaling, so testosterone upregulates endothelial and neuronal nitric oxide synthase, and low testosterone level can cause decreased cyclic GMP signaling. And smooth cell connectivity changes, androgens are mainly responsible to maintain cavernosal smooth cell content and inhibit fibrosis. So low testosterone can lead to increased collagen deposition, decreased smooth cell mass, and they can cause veno-occlusive dysfunction. In metabolic inflammatory oxidative pathway, inflammation, oxidative stress damage endothelium, nerves, and worsens ED, and psychosexual effects and libido. Testosterone drives libido, so low libido reduces sexual stimulation and erections. So, if we summarize the role of testosterone in erectile function, it is the nitric oxide pathway, neural regulation, and vascular function, which are intricately related for the erections. So, how to evaluate this? We should first see for the symptoms of low testosterone levels, that is reduced libido or erectile dysfunction, decreased energy and fatigue, low muscle mass and strength, increased body fat, particularly visceral fat, increased body fat, and mood changes in the form of depression and irritability. We can do the physical examination. If we find low symptoms of low testosterone, we do physical examination. We can find small or low testis, reduced body hairs, gynecomastia, decreased muscle mass, and reduced bone density can also be seen. Then we go for lab values for taking testosterone. It is usually less than 300. Two separate measurements have to be taken on 2 separate days. The sample should be taken between 7 to 11 am where the testosterone levels are very high. If the repeat test is also low or it is in the lower normal range, then we have to do LH, FSH and prolactin to find out whether it is from pituitary or it is whether it is hypogonadotropic hypogonadism or hypogonadotropic hypogonadism. We should also look for sex hormone binding globulins, fasting glucose, lipid profile. Optionally, we can do for free testosterone and pituitary imaging if required. When to consider testosterone replacement therapy? When the patient is symptomatic and having consistently low testosterone, we should consider risk of erythrocytosis, prostate concerns, cardiovascular risks, and contraindication if the patient is having untreated prostate or breast cancer. Replacement therapy improves the erectile function, is seen in many men with low baseline test, but not all men with erectile dysfunction respond to testosterone replacement therapy. Available formulations are intramuscular injections, transdermal gel, transdermal patches, buccal tablets, and subdermal pellets. If we compare the efficacy, monotherapy gives improvement to 35 to 40%. If we add it with the monotherapy with phosphodiesterase 5 inhibitors, improvement is 60 to 70%. However, if we give combination therapy, there is the highest efficacy between 65 to 92%. This is the flow chart how we should go about it. If the man is having sexual dysfunction, we should look for symptoms and for low testosterone, as we have already discussed. If the features of testosterone deficiency are there, then we do fasting morning testosterone level. If they are less than 300, again it is to be repeated, and if repeat levels are again less, we go for LH, FSH and prolactin to find out whether it is hypogonadotropic or hypogonadotropic. And if the testosterone deficiency features are not there or testosterone levels are not less, we can start off with beta-5 monotherapy. However, if the symptoms are there and testosterone levels are repeatedly low on 2 occasions, we do a pre-treatment assessment doing CBC, PSA levels, rectal examination and cardiovascular counseling, and then we give testosterone replacement therapy. If the erectile dysfunction is still persist after testosterone therapy, we can combine the therapy with phosphodiesterase 5 inhibitors along with testosterone, and regular monitoring with the symptoms, CBC, PSA and testosterone can be done later on. So what are the practical tips? Measure testosterone levels early morning and repeat if they are low. Address reversible causes in the form of medication, obesity, sleep apnea and controlled diabetes. Start replacement therapy when indicated with baseline PSA and hematocrit and monitor regularly. Use phosphodiesterase 5 inhibitors as first line in therapy for ED unless contraindicated. A relatively low testosterone can meaningfully contribute to erectile dysfunction. Evaluate for testosterone status and common organic or cytonic cause of ED. Testosterone replacement therapy can improve libido, may help in erectile function in hypogonadal men. Therapy should be individualized. What are the controversies? The threshold for defining symptomatic low testosterone vary. Long-term cardiovascular effect and prostate effects are to be investigated, and predictors for ED response to testosterone replacement therapy are imperfect. To summarize, endocrinopathy is a rare cause of erectile dysfunction, but within this category, hypogonadism is the most common, that is low testosterone level. Normal adult testosterone level are not necessary for normal erections. There is a gradual decline with the age of total and free testosterone level. ED and hypogonadism are common in aging male, but they may not be causally related, and treatment with exogenous androgens may produce clinical improvement in the signs of hypogonadism, but may or may not improve sexual function. Thank you.